Good afternoon, everybody. I have the pleasure to introduce Dr. Maria Antonietta Mosetti. She graduated from the University of Sapienza in Rome, in Italy, in 1997, completed a research fellowship in vascular radiology at UNC in 2002, followed by a residency in internal medicine. After practicing in Italy for several years, Dr. Mosetti moved down to the University of Miami and currently serves as an assistant professor in the Division of Hospital Medicine since the year 2016, where she also serves as a medical director and longitudinal clinical educator at the Miller School of Medicine, where she teaches medicine as a profession. For over 25 years, she has experience in point-of-care ultrasound, and holds credentials and certifications both in Europe and in the United States. Serves as a director of clinical ultrasound course for the internal medicine residency program, is a fellow of the American College of Physicians, and has been invited annually to teach POCUS and POCUS-guided procedures at the ACP National Convention. Please join me in welcoming Dr. Mosetti.
Thank you very much. It is clearly a privilege for me to be here today. I'm presenting point-of-care ultrasound current indication and future perspectives. The objective of today's presentation are to discuss the application of POCUS in clinical practice, to review the updated medical literature for point-of-care ultrasound, and to analyze some credentialing process and future application. I'm going to do this for the first few minutes, talking about an overview of ultrasound. I'm going to show you some cases and some interesting, hopefully, clips. We're going to review some of the updated literature of 2025, and we're going to review credentialing and hopefully the near future. A little bit of history, if you don't mind. Lazzaro Spallanzani was an Italian physicist. He was a priest, and for the first time, he described echolocation. You might ask what bats has to do with ultrasound, but in reality it's all there, meaning that bats and other animals have this ability to echolocate. They emit signal and they receive signals back. Instead of looking for their prey with the eyes, they receive signals, and that's the principle of echolocation. A century later, the Curie brothers discovered piezoelectricity. There are some quartz in nature that have the physical ability to vibrate once you apply an electrical source. And these generate an echo. This is still the basic principle of our transducers. So at the tip of our transducers, you'll find a modern version of the piezoelectric crystals. Fast forward 100 years, the first description of hemoperitoneum. It is still the basic of the FAST exam. Focus assessment with sonography in trauma was described by a trauma surgeon who in the combat field didn't have much more than his hands to detect intraperitoneal bleeding, or the peritoneal lavage, which is a sort of rudimental paracentesis. So in that specific scenario, ultrasound shows promising application in detecting fluid in the intraperitoneal cavity. FAST stands for Focus Assessment with Sonography in Trauma, and is the beginning of the new era of POCUS. This is a personal history, if you don't mind, but I want to show you what in 2000 the machine looked like. This is the Seconda Clinica Medica in University La Sapienza in Rome, and we were already very lucky to have a machine to use for residents. And we were also already having this concept of portability, despite, you see, this machine has wheels, so it is portable. But I was part of a larger research program We literally grabbed part of the machine, put it in the car, and we were scanning the population of a southern Latium area that has an unusual prevalence of endemic goiter. This is for low iodine in the water. So we published this study, and it's the year 2000. The reason why I'm getting so emotional talking about 2000 is simply because that's the beginning of a new era. In 2010, the machines were totally different, and we already have this amazing detail with portability, software. Until nowadays, we have wireless devices like the butterfly on the picture, where you simply have a machine and you plug it in your phone. It's not only portability, but it's also that the machines are becoming very cheap. So for us as a responsibility, in theory, every student can come, every resident can invest a little money and run with this little device. So ultrasounds are sound waves that travel at the velocity above the human threshold, so above 20,000 hertz. We use in diagnostic ultrasound a frequency that ranges between 2.5 and 14 megahertz. So a little rudimental, but very clear. This is how ultrasound works. Remember the piezoelectric crystals? They're right here at the tip of our transducer. We plug in the machine and the transducer starts to generate an echo. The echo goes and comes back with some characteristics that the machine elaborates with the software and is showing in the scale of gray with basically two characteristics, the depth and the echogenicity. This is the heart, and the echogenicity appears, for simplicity, what's hyperechoic. We call it hyperechoic instead of white from now on. And anechoic is black on the screen and is likely fluid. This is an example of our transducers. Only two types of transducers in terms of frequency. We have high and low frequency. High frequency is in reality limited to superficial structure, thyroid, breast, veins, artery, musculoskeletal. And in this clip above, you see the pleural line, this hyperechoic rim that slide. It means that we can rule out pneumothorax in this area below. This is another clip. We're using a low-frequency probe, which is used for deeper structure. I don't know if you can see, but on the right, you have the centimeters, and we are at 15 centimeters here. So everything else is low-frequency, heart, abdomen. And at the end, what I want to show is that ultrasound is safe. There are no biological effects to patient and operator at the frequency used in diagnostic ultrasound. So let's start with a case. 48-year-old woman who previous ureteral stent and recurrent UTI present to the ED for fever and chills. The patient is found to have UTI and sepsis. Labs on admission show mildly elevated creatinine at 1.3 from a normal baseline, leukocytosis and lactic acidosis. In the emergency room, imaging show no hydronephrosis, normal kidneys, and the patient is started on IV antibiotics and IV fluid. She gets better by day 2. Leukocytes are trending down, lactic acid is normalized. Urologist says nothing to do, discharge the patient, and we'll remove the stent later on. But the date of the discharge, the patient creatinine is not back to normal yet. She complains that she has maybe fever at night, which was not recorded. And what would you do? You can still discharge the patient since it's on IV antibiotics. You can order a CT abdomen and pelvis with some radiation and contrast. You can continue monitoring one more day, and maybe the creatinine will be better in the morning, or perform a POCUS renal ultrasound. These are all questions that probably you can answer correctly, but considering the topic, the right answer, at least for us, was to perform a renal exam. It's the safest choice. It's also the less invasive. You can do it in real time. And the patient had, if the one on your right, on the left of your screen is a normal kidney, the one on the right is hydronephrosis. Thank you so much. It's excellent. So you see the run on the right is clearly, you can see the pyramid much more pronounced, and this is why we call it moderate to severe. The total thickening of the thinner of the cortex will be a severe hydronephrosis. Patient was fine, and we removed the stent, and she was discharged a couple of days after. So what is POCUS? Point-of-care ultrasound is a goal-directed examination that answers a specific diagnostic question or guide a bedside invasive procedure. What I want to point out is that what makes POCUS different from a radiology-based consultative ultrasound is that the operator is the same person as the clinician. So I have a clinical suspect and I analyze it in the with the point-of-care ultrasound. For guidance, for procedure guidance, there is ample literature over the last 20 years. Just to name one, ultrasound-guided versus landmark CVC insertion is associated with a dramatic reduction of infection, 35% lower rate of central line-associated bloodstream infection, 100% success rate, and 0% of hematoma versus 8.4% without ultrasound. So we can agree that POCUS is bedside, is portable, is non-invasive. You can repeat exam before and after intervention as many times as you want. And there are some disadvantages. The POCUS is machine, patient, and operator dependent. In other words, if you don't know what you're doing or you're looking at, or if the machine is not ideal, and if the patient has not the right body habitus, probably POCUS is not the right choice. So POCUS is classically known as designated to answer in a binary manner simple question. For example, the imaging on the left is the Morrison pouch, and I don't see any anechoic material, so I will answer no, there is no fluid. The new imaging on the right of the screen shows this small anechoic rim of fluid right here. Even more so here, there is clearly a lot of fluid. And we can also answer another question. Can you tap safely this effusion? And the answer is yes, because there is enough distance between the skin and the bowel loops that we see down here. So I can insert a needle and then throw a catheter and aspirate all the fluid. In reality, we're still using POCUS answering yes or no question, but experienced physicians have been done POCUS for a long time, and societies are trying to use a more sophisticated way for POCUS. We are trying to answer complex clinical question with a multi-organ assessment. Let's see if I can show you this case. 34-year-old obese African-American woman. She has history of CKD, COPD, diabetes, chronic lymphedema, sleep apnea. She presents for chest pain and shortness of breath. She's admitted to medicine for further stabilization. Labs on admission showed a creatinine of 3.5 from a baseline of 2.8. Potassium is 4.1. BUN is elevated, and the troponins are elevated, but they plateau by day 2. EKG shows diffuse ST modification with no ST elevation, chest X-ray, not really the best respiratory effort, but no frank pulmonary edema. The echocardio shows a large right atrium, normal ejection fraction, and no regional motion abnormalities. Trace pericardial effusion. So we call cardiology, a little concern about this chest pain. We call nephrology for the volume status, and 2-3 days went by trying to optimize the volume of this patient. The patient's main complaint was this severe chest pain. On day 3 or 4 of the admission, I remember it was a Saturday, we went to the bedside and the patient couldn't lay flat. She was obtunded, she was confused. So bedside ultrasound, clearly the patient was uremic, but for point-of-care ultrasound for us was important to prove to our nephrology colleague the need for dialysis. We agree, and that day we were together in the room with ultrasound. So this is what we saw. This is the pleural line that we learned to recognize. These are B lines, which are artifacts that generate from the pleural line that are not normal, are seen in the case of, in this case, pulmonary edema. We did a parasternal long axis view of the heart, and we saw this anechoic rim of fluid in the apex. So this is an apical 4 chambers, means that in the cardiac setting, the left of your screen are the right chambers, and the right of your screen are the left chambers. So this is the left ventricle, mitral valve, left atrium, and descending aorta. Even better in this picture, this is a parasternal long axis, and this is the left atrium, the mitral valve, the left ventricle. This is a fluid around the heart. And once identified the descending aorta, we increase the depth. And apart from pericardial effusion, we see pleural effusion. So the descending aorta helped me to differentiate what's anterior, which is pericardial, and what's posterior, which is pleural. It's not always that simple, so sometimes you really need to understand if the fluid is one or the other, and the descending aorta is the landmark. We checked their IVC. The IVC was enlarged with poor respiratory collapse. This is a rare normal IVC just to show you the sniff sign. So means that the IVC is totally collapsing. And if we refer to this chart on your right, the IVC can correlate with the central venous pressure. In this case, IVC enlarged, poor respiratory collapse. The central venous pressure estimate is at around 16, 17. So the patient needed dialysis, not only for volume control, but because the chest pain was a pericarditis, was a uremic pericarditis, and not surprisingly, she got better quickly. So what if we could not only be happy with our clinical judgment and support it with ultrasound, but what if we could prove that ultrasound is also associated with reduction of length of stay? My division chief will be happy. But what if I can prove that the reduction of cost between a hospitalist that use POCUS and one that doesn't, it's dramatically reduced? We don't have the evidence yet, but some colleagues, and this is a group based in New Jersey, published the study in 2025. You can find it in JAMA Network. They basically wonder, is cardiopulmonary POCUS associated with reduced length of stay and hospitalization cost in a patient with undifferentiated dyspnea? They basically associated for 6 months patient to admitted in one of the 5 medical team with standard care of approach or POCUS. 84 patients in each arm using parasternal long axis, short axis, 4 view for each side of the heart, and IVC. And their outcome, the primary outcome was length of stay, and the secondary outcome was hospitalization cost, and their data are interesting. Implementation with POCUS was associated with a 30% reduction in expected length of stay, and based on cumulative assessment, POCUS was associated with a total reduction of 246 hospital bed day, with direct cost saving of $751. And something that I want to note is that these physicians were not POCUS experts. They were POCUS naive, and they received training for this study. If they were not feeling comfortable, then sonographers would perform POCUS. And only 20% of the hospital use it independently. They answer, I didn't have sufficient training, or I was too busy caring for my patients. We'll talk more about this. I anticipated some challenges, and here we go. One challenge is the training. Are we training all in the same way, our students and residents? And number 2, credentialing. In terms of training, I was lucky because when I decided to present POCUS, this article was released, and it is actually still in press, was accepted for publication in the American Journal of Medicine in June 2025. It's done by a panel of experts in the United States, colleagues from Charles Lopresti, who is in Cleveland, David Cherney, who is in Minnesota, colleagues from all over the United States that have been doing point-of-care ultrasound and residency program training for a long time. They basically put together this panel. They are both inpatient and outpatient, and this is an important point. And they identify 12 core diagnostic and 6 procedural indication. This study, and I keep on saying it's important just because it's one of the first consensus, at least in the United States, not only for experts, but also is evidence-based. And this puts some recommendation for what elements should fall into a core internal medicine residency curriculum in the United States, which translates, since my generation of physician, and correct me if I'm wrong, I am 53, but my generation of physician were not trained in ultrasound here. So if we want to train our residents, this translated, this is also what we should know. It's a nice picture. Allow me to explain. So this circle, the gray, is the core indications. And the colorful one, external, are the core applications. So let's say that we stick with dyspnea, like the previous study. If a patient comes from dyspnea, I should do a lower extremity study to rule out DVT, inferior vena cava to assess volume. I should do focused cardiac, and then chest for free fluid, pleural ultrasound, and lung ultrasonography. Or let's say that a patient comes from AKI. Let's go on the other side. I should simply do renal and urinary ultrasound. And this is true for different indication. For procedural guidance, were approved, met the 75% consensus, thoracentesis, paracentesis, LP, central venous, catheterization, and arthro and peripheral IV. These are more of skills by application. And this is our experience here. We have been doing an ultrasound course for the residents since 2016. This is year number 9. And we're very proud because we collected many data. So we trained more than 350 residents. Apart from being rated as a very pleasant elective, we also have an amazing return of residents that feel very comfortable doing ultrasound. We are also proud since everything that is in this new study is in our course. We are collecting all the data thanks to Dr. Tonk, Sebastian, and Roxanne that are here today. We hopefully get this published soon. And another important part that I want to stress is the credentialing. So credentialing, I heard many times that there is no board of credentialing for internal medicine and POCUS. We might answer that there is no credentialing for physical exam either. But it's true that in the American Board of Internal Medicine exam, there are questions about ultrasound. So this has to be part of our residents and student background. There are many academic societies that offer formal training in ultrasound and certification, they're long, sometimes very expensive, but our institution should have an effort in creating an internal credentialing process. Some colleagues this year published a quality improvement study where they wonder what factors play a role in point-of-care ultrasound on ultrasonography privileging and credentialing. And one of the consensus is that external factors are, for example, diverse stakeholders, meaning that different specialists with passion or interest in ultrasound should be involved in creating the guidelines. And then implementation, of course, it's harder than it looks, but it required funding, training, software update, and some cultural and knowledge barriers. I promised something about the future, but future is already here in the case of POCUS. So AI is transforming POCUS by implementing training, imaging acquisition, interpretation, and reporting, and most of all can address operator dependency and interpretation variability. A study, and I'll go quick, shows that, yes, there is a lot of enthusiasm in using AI. This is a study published this year in the Ultrasound Journal. But as a matter of fact, it's not in use in POCUS as yet. I wanted to show where else I would love to see ultrasound. This is a study that we recently published with the team at the Gordon Center. We train paramedics, and it would be nice to make an hypothesis of having a POCUS in the helicopter for patients that are transported from remote places with trauma, and directly the ultrasound imaging could be sent to the trauma center. And this is apparently these are two very different imaging, but it's the same concept. On the left of your screen, it's the Advanced Diagnostic Ultrasound in Microgravity. It's a NASA-sponsored project since 2022. You have limited space out of space, so you can use ultrasound to diagnose problems that are transmitted, imaging are transmitted via telemedicine on Earth. On the imaging on the right instead, it's a rural community in Las Salinas in Nicaragua. The concept is the same. You're training physician and you transmit the imaging to somebody else that can read them. So in conclusion, I hope I was able to prove the clinical impact of ultrasound that enhanced diagnostic and therapeutic decision at bedside. National, international, academic society continue to develop standardized POCUS guidelines. And I think the last point that I want to make is that expanding access in low resources and underserved country can facilitate care with our support. And I suspect I'm done. I thank you so much.
That was great. Thank you, Dr. Mosetti. Wait. We have to give you a little question. While people in the audience are thinking of what questions they have. So this was very, very interesting. And I guess, again, I think ultimately the onus is on you to provide the data to show that this really does affect length of stay and quality of care. And that's going to be difficult and take some time to do. Now, all of this is taking place in the inpatient setting. I'm wondering where, in terms of internal medicine training, in terms of actual practice, in our ambulatory clinics, do you see the major impact of point-of-care ultrasound being?
Thank you, Dr. Weiss. And clearly, this is a very up-to-date question. It is true that outpatient, these guidelines apply also to outpatient, the outpatient world. And there are two parameters where the outpatient physician are trying to incorporate ultrasound. One is patient satisfaction. Patients love to have a physician dedicating more time to explain them something else, like I'm doing this ultrasound for you. And number two, cutting a little bit the expenses of other exams that can be done. So it is true that also our patient world is trying to enhance the application for ultrasound.
Great. I guess the cost-saving measure would be somewhat tempered by the fact that you find an abnormality, you might want to confirm that by a radiologist in radiology with an official ultrasound. Maybe not. Okay, well, thank you, Dr. Mosetti. That was a great review, and we appreciate it very much. Dr. Chatzis.
All right, so good to go. Okay, so good afternoon, everybody. I have the great pleasure today to introduce Dr. Aditya Bharadwaj for the prestigious Department of Medicine Grand Rounds. Dr. Bharadwaj is a nationally recognized interventional cardiologist with particular expertise in cardiogenic shock and complex core interventions. He earned his initial medical degree from the Bangalore Medical College in India. Then he came to the US to pursue the dream, starting initial training in Detroit Medical Center, then Loma Linda for cardiology fellowship in California. Then he went to the great Mount Sinai in New York for his interventional cardiology training, and then back to Loma Linda to become faculty. He's very actively engaged in the field of complex coronary interventions and shock through his participation in multiple clinical trials, engagement with societies like SCI, the Interventional Society of Interventional Cardiology in the US, American College of Cardiology. He's lecturing in the field nationally and internationally. And of course, he has earned multiple awards, including awards from the SCI and the American College of Cardiology. He has been recruited at the University of Miami as the director of the cardiac cath lab and the director of the cardiovascular clinical research. His mission is to advance the field, and we're very, very to hear get enlightened with cardiogenic shock. Welcome. There you go.
Thank you so much for that kind introduction. It's indeed a huge honor and a pleasure to be here today. And we're going to dive right into this very complex topic of cardiogenic shock. I'm going to try and hit upon some contemporary best practices and a multidisciplinary approach to shock. These are my disclosures. So the learning objectives over the course of the next 25 minutes or so are going to be to describe the challenges in diagnosis and treatment of shock, cardiogenic shock, to evaluate data relating to the use of mechanical circulatory support. And finally, we'll finish up with appraising the benefits of a multidisciplinary team. And I think that's why this Grand Rounds presentation is so important, because a lot of key stakeholders who are going to be taking care of cardiogenic shock patients are present in this room. So let's start out with some basics. Definition of cardiogenic shock. I think this is something that we're all quite familiar with. It's really defined as a state of critical end organ hypoperfusion due to a reduced cardiac output. And there's blood pressure parameters to define that: a systolic blood pressure of less than 90 millimeters of mercury, sustained for greater than 30 minutes, or vasopressors to achieve that degree of support. Very important. Usually accompanied by signs and symptoms of shock. There's pulmonary vascular congestion, there's elevated left ventricular filling pressures, and on physical exam, there's signs of impaired organ perfusion. Patients have cold, clammy extremities, they have altered mental status, they're oliguric. Magnitude of the problem, I think this really will set the stage as to why this topic is so important. It's really sobering to see that despite all the advances that we've made in medicine, cardiology, interventional cardiology, you can see that the mortality of patients with cardiogenic shock continues to hover in that 40 to 50% range. And the line here in green, do we have a pointer? Does this have a laser? It does not. Okay. So the line here, yes, thank you. So the line here at the bottom actually represents patients who present with just acute MI. And you can see that we've done a phenomenal job in reducing the mortality down to 1 to 2%. But the minute patients have cardiogenic shock, their mortality goes up to 40 to 50%. So what are some unique challenges in treatment of cardiogenic shock? There are challenges with respect to diagnosis, challenges with respect to treatment, and finally, challenges with respect to organizing systems of care to take care of these patients. First of all, there's variable definitions of shock. For the longest time, different clinical trials, different disciplines have defined shock in different ways. There's different phenotypes of shock. We're beginning to recognize that even more now. There's need for invasive hemodynamic data. We often require a Swan-Ganz catheter, right heart catheterization, to actually accurately diagnose shock and see which phenotype they belong to. But most importantly, it is a time-sensitive condition. Time is of the essence, and there is data to show that with every passing hour, the mortality actually increases in these patients. As far as treatment is concerned, even within the cardiology community for the longest, and even to this day, there is a lack of unified consensus in how to treat these patients. There's significant variation in care. It's almost embarrassing to say this, but even in 2025, patients who present with cardiogenic shock get treated differently at different hospitals. Even two hospitals in the same city across the street patients are treated differently. There's different MCS devices available. There's challenges with running randomized controlled trials. Like you can imagine, these are very sick patients. They're actively dying. Recruiting them into randomized controlled trials can be a real challenge. And importantly, we've realized that one size does not fit all. The treatment strategy really has to be tailored based on that specific patient that we have in front of us. Other important thing is that, unfortunately, we cannot treat shock in isolation in our own silos. We do require systems of care at an institutional level and at a community level to actually take care of these patients. This is the stages of cardiogenic shock. This is something that some of you may be familiar with. So the Society of Coronary Angiography and Interventions, the SCAI professional society came up with these stages a few years ago, and that has really sort of provided as a universal language in terms of actually categorizing these patients and being able to identify how severe they are. I'm not going to go into the details of these, but I think I just want to point out that it is a pyramid system of classification, starting out with patients who are in SCAI stage A, who are at the bottom of the pyramid. These are patients who are at risk. And as you go up the pyramid, the severity of shock increases. Beginning stage, classic stage. So classic stage is, I think, hopefully we can all diagnose and pick up. These are patients who are hypotensive and who are hypoperfused. Deteriorating patients are those who are doing poorly despite the initial set of interventions. And then, of course, you have patients who are in stage E or extremis who are doing poorly despite everything that you've tried. Just a slide to show that this classification has been validated both in the ICU as well as the in-hospital setting. This is just one example from Mayo Clinic where they looked at their patients, where they showed that as the SCAI stages increase, the mortality significantly increases. And this was a publication back in 2019, but since then we've had multiple other validations to this system of classification. Pathophysiology of shock, this kind of looks like a very confusing slide, but the bottom line is that basically, there is some sort of a myocardial dysfunction that sets off this cascade of decreased cardiac output, decreased stroke volume, hypotension, decreased coronary perfusion, leading to ischemia, further causing myocardial dysfunction and ultimately leading to death. Likewise, acute onset of a diastolic dysfunction also increases left ventricular and diastolic pressure, pulmonary congestion, as well as hypoxia, all of these ultimately causing the patient to go into this death spiral, as we call it. Let's switch gears a little bit and try and understand mechanical circulatory support devices. So one of the ways of getting patients out of this death spiral that I just described is by using mechanical circulatory support devices. So balloon pump, I think this is something that you're all quite familiar with. It's a relatively older technology, works by the mechanism of counterpulsation. Then we have Impella, which is a forward flow pump. It's a percutaneous pump. It's a microaxial pump which draws blood from the left ventricle and it expels it into the aorta, so it directly unloads the left ventricle. Then we have tandem heart, which requires a transeptal puncture. It draws blood from the left atrium and is able to directly decrease the left-sided filling pressures. And then we have VA ECMO, which is typically what is used in the setting of cardiogenic shock, which provides biventricular support and is able to oxygenate blood when we get these patients on an ECMO. Those were just the left-sided devices. Like I said, ECMO does provide biventricular support. Then there are dedicated right-sided devices which provide right ventricular support. There is, again, the Impella family of catheters with the Impella RP catheter. And then there are other devices which are both percutaneously as well as surgically implanted right ventricular assist devices. So there's a lot of different types of MCS devices, and the question is, how do you use when and in what situation do you use which device? And sort of this kind of gives a broad overview as to when we would consider using these devices. So for predominantly LV failure, which a lot of our patients are, Impella, tandem heart, or balloon pump can be used. If it's predominantly RV shock, then we ought to use the right-sided support devices. If it's respiratory failure, like our colleagues in MICU typically use VV ECMO if it's just respiratory failure. And when you have a combination of all these, when you have biventricular shock along with respiratory failure, that's when we go for a VA ECMO. So let's switch gears a little bit and talk about some of the data supporting the use of mechanical circulatory support devices. I will tell you that it has been really hard to generate this data just enrolling patients in cardiogenic shock. These are very sick patients, like I said. So we'll start off with the initial trial, which was the IABP shock trial, which was a randomized controlled trial, NEJM publication in 2013, which basically showed that using a balloon pump in patients with acute MI cardiogenic shock did not actually improve outcomes. There was no difference in primary endpoint at 30-day, which was 30-day mortality. Even looking at an extended endpoint, we have data up to 1 year and 6 years, which was subsequently published. Unfortunately, there was no benefit of using a balloon pump in this situation. In 2023, we had the ECLS shock trial, another large trial looking at ECMO as first line for patients presenting in acute MI cardiogenic shock. Again, very disappointing to see that no difference in 30-day mortality when it actually came to these patients who were treated with ECMO. And then we have the relatively more recent danger shock, which looked at Impella. And this trial took 10 years to enroll and was mostly conducted in Europe, in Germany, Denmark, and then in the UK, which showed that Impella was associated with a significant reduction in mortality. There was a 12.7% absolute reduction in mortality with the number needed to treat of 8. And this was specifically in patients with left ventricular involvement with STEMI presenting with cardiogenic shock. So a very specific group of patients where there was found to be a benefit. So the question is, so now we have patient selection we've talked about mechanical circulatory support. The third most important part of the puzzle is how do we develop an algorithmic and a protocol-based approach so that we can tailor the treatment to that specific patient, like I mentioned. And the answer to that comes from insights from the National Cardiogenic Shock Initiative. This was a large initiative that was led by Dr. Bill O'Neill, who was here a few years ago. So this was, over 400 patients who were enrolled all across the United States. There was a mix of both community as well as university hospitals. At my previous institution in Loma Linda, California, I was fortunate to be part of this trial, and we were one of the highest enrollers in this trial. But the bottom line is that, these were patients who were treated with early mechanical circulatory support. There was a lot of emphasis on early recognition of shock, early use of Impella for unloading. And the key was to avoid escalating doses of vasopressors, which we often see happens in our units. These patients, we keep going up on their vasopressors and inotrope support, which we know is actually detrimental to the pathophysiology of shock. It increases their afterload and increases their contractility, both of which are actually bad things to do when somebody is in cardiogenic shock. And then, of course, I'll talk about this shock team, which was employed in all these patients who were treated. But the key is that, we had greater than 71% survival in these patients, which, again, is actually quite remarkable when you look at all the shock trials in the past. Like I said, the survival has been in the range of 50%, at best, low 60s. So to have a 71% survival, of course, this was observational data. This was not a randomized controlled trial, but I think this is this definitely gives credence to the theory that we ought to have an algorithmic and a protocol-based approach. So some best practices that came out of Cardiogenic Shock Initiative. So first of all, we have to implant the mechanical circulatory support before we do PCI, before we revascularize the patients. Time is of the essence in these patients. Door to support of less than 90 minutes was one of the metrics that we tried to meet. Established TIMI-3 flow, meaning you open up the blocked artery, which we do in all patients who are coming in with a myocardial infarction. We utilize right heart catheterization to make decisions about when to escalate or de-escalate MCS support. We wean inotropes and vasopressors, very important. I think this is sort of a paradigm shift in the mindset. We want to get these patients off of vasopressors and inotropes before we explant the MCS device. And then for those of you who are interested, I'll be happy to chat more in detail, but there was the cardiac power output, which was the hemodynamic parameter, which was very important, that not just came out of NCSI, but even before that. This is a very strong predictor of mortality in patients with cardiogenic shock. So the 0.6 is that magic number. So whenever we treat patients in shock, our goal is to maintain that cardiac power output of greater than 0.6. So whatever it takes to achieve that degree of support with MCS devices, that's what we're striving for. And the goal, of course, is to achieve a greater than 80% survival in these patients. Now, this is something that I mentioned at the beginning of the talk. Shock is a team sport. It's not just cardiologists, not just interventional cardiologists. So we require really systems of care at an institutional and at a community level to actually treat shock. I'm not going to go into the details of this, but it will suffice to say that at this point, we have a lot of data coming out from single center as well as multi-center trials to show that when you use shock teams to treat patients at your institution, you will see an improvement in the survival of patients with cardiogenic shock. You'll see a greater percentage of PA catheters used. You'll see a greater percentage of MCS devices used, which translates into improved survival in these patients. The hub and spoke model, this is something that I want to briefly mention. So really the way shock care is going to be structured, I think going forward, probably in the next 5 years, hopefully, is the way trauma care is set up in the United States. You have different levels, level 3, level 2, level 1 centers. So the level 3 centers are the ones who are initially capable of diagnosing shock. They transfer these patients to level 2, which are the STEMI capable centers, and they may have 1 or 2 basic mechanical circulatory support devices available. And level 1 centers, these are the comprehensive shock centers, which we really want University of Miami to be. The level 1 centers are sort of the tertiary care centers where you're able to offer them the entire array of mechanical circulatory support, escalating support in these patients. And ultimately, if these patients were to require a heart transplant or a durable VAD, then there are opportunities to do that at these level 1 centers. Finally, before I finish and take questions, I want to bring up this very important point about building a cardiogenic shock program. This is what a lot of institutions across the country and the world are talking about, because like I said, it's not one specialty that treats shock. A lot of specialties get involved in the care of these patients, starting actually from EMS to emergency medical services, to the emergency room, to hospitalists, to MICU, to cardiology, interventional cardiology. Even within cardiology, we require collaboration from our heart failure colleagues, interventional cardiology, and then, of course, cardiothoracic surgery if we require escalation of care. So it's a lot of different disciplines coming together to treat these patients. And oftentimes we require resources to do it. So we need buy-in from the hospital administration. So really the entire community has to come together to build these shock programs. And we published on this last year in Journal of in JSky. So basically it's a number of different steps, but sort of a high-level overview is, we start out by measuring the outcomes at our institution, the champions, which I mentioned some of those. We develop protocols, or we adopt protocols that have already been successfully developed. We change the organization. I think this is where these kind of grand rounds and other meetings come in. We have to educate our own institution and tell everybody that this is what we're doing, this is the protocol that we're following. And then we go out and educate the community, because a lot of these patients who present in shock present to community hospitals. They don't get to pick and choose which hospital to go to. Then we consult experts. If we run into questions, we ask people who've already built these successful shock programs. And finally, we go live and we start the shock program, but that really is just the beginning of the journey, because it's a constant process of quality improvement as we review cases and as we see how we could actually improve. So with that, I want to really leave you all with 3 important conclusions. The first one is that cardiogenic shock, it's a very heterogeneous condition. It's a time-sensitive condition. There's significant challenges with respect to timely diagnosis and treatment. Secondly, as far as mechanical circulatory support devices are concerned, we have data from randomized controlled trials showing that balloon pump and ECMO don't really have a whole lot of benefit in these patients as first line. ECMO, I think, has an indication as an escalation device, but not as first line. The microaxial flow pump, which is Impella, is the only one that has been shown to have improvement. And I definitely want to leave all these devices with a disclaimer that all these devices are associated with complications, vascular complications, bleeding complications, and that is a whole different discussion as to how we can mitigate these complications. And finally, like I said, it's the algorithmic care of shock with invasive hemodynamic monitoring and a multidisciplinary approach that will actually improve outcomes of these patients. And I think, this is not just with regard to but this is, I think, just with regard to shock care everywhere. I think we have a long way to go and the journey has just begun. Thank you.
Thank you, Dr. Bharadwaj. That was a very clear and excellent presentation. So we can turn the lights up. So I appreciate all these protocols for escalation, when to use devices and so forth, but is there any data and any thought given to how to de-escalate aggressive treatment in patients in whom the resources that are involved in this tremendous heroic effort to save lives really has a diminishing return?
Yeah, that's a great question, Dr. Wise. And I think there were two questions embedded in your question. The first was the de-escalation part, which I think we have data. We have objective data as to how to de-escalate. These should not just be based on clinical judgment. I mean, there's obviously a lot of clinical judgment that comes into play, but we need objective data based on the Swan-Ganz catheter numbers, based on the right heart catheter numbers. What is the wedge pressure? What is the cardiac output? How many pressors is the patient on? So it's based on those data, and there are algorithms that are there. In fact, the danger shock study that I said, there's a huge supplement in NEJM which beautifully describes the de-escalation protocol that they followed. And the second part of your question regarding almost the futility sometimes in the use of these expensive resource utilizing devices and gadgets. I think this is a very evolving discussion at this point in time. We really don't have risk prediction models and so on to decide, who we should offer these therapies to, who we should not. We have some indicators in terms of which patients are going to do poorly based on age, based on comorbidities and so on. But I think that's a very evolving discussion, and hopefully going forward, we will have more granular data in terms of deciding which patients we offer these expensive therapies to.
I'd like to thank both our speakers for today's grand rounds. They were excellent. I want to congratulate all our residents who matched. We'll go downstairs and congratulate them personally. I want to remind everybody to check the QR code upon leaving, or those online to check the chat so you can get your CME and MOC credit. Wishing everybody a great day. Take care of yourselves, take care of each other, and we'll see you next week.